host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request Dr. Amit to start this session. Welcome, sir. Over to you.
Thank you, Dr. Navneet. Good morning, everyone. Today our topic it's somatic genomic testing. Who, what, and when. There's been a little bit of jumbling in the words when we saw the topic, but this is what I will do, and I want to really talk from a clinical point of view. I'm a clinician and a medical oncologist, so I want to tell you about a clinical point of view. What is this testing, and how do we use it in clinical practice? So before we come to the what we need to understand is the why. And it's very important now. We know what is cancer, and it's uncontrolled cancer growth. Cells are multiplying and continuously, and that's what's causing cancer. But we know why it is being caused now, and it is being starting off with some amount of abnormality in the genome. And it is a genetic hit which causes the gene abnormality to happen. We know that causes abnormal altered proteins, and that leads to altered pathways. And eventually that leads to our growth, division, and death of cells. And the whole process of cancergenesis takes place this way. We have understood the hallmarks of cancer, and we've understood more and more in the pathway and hallmarks of cancer. There are multiple ways of the cancer, and all of these hallmarks of pathways are involved with some genomic abnormality. And it is understanding this that has become very important, and it has become of clinical use. So let's start with first terminologies. We should be very clear when we talk about when we are testing what we mean by the test. So what are the types of mutations which we are looking for? We are looking for, it could be, depending on the origin, it could be germline or it could be somatic. Now, when we say genomic testing, that's the right word to use. Because when you say genomic, you're covering the genes, and the genome, it could be germline or it could be somatic. But if I say genetic testing, then I'm clearly saying I'm doing only germline testing. So one should not mix and say we are doing genetic testing when we are actually meaning we are doing genomic testing. So genomic includes germline and somatic. Now we know what germline means. These are the mutations which are present within the egg or the sperm, and they are the ones which are heritable. We know germline mutations are the ones which are passed on. They will be present in both the tumor cell and also the normal cell. So when we sequence, we may get an information which is there in tumor and in the normal cell, we say that is a germline mutation. Now, when we do germline sequencing testing, what is our emphasis? Our emphasis in focusing on pathogenicity of a variant for understanding the disease causality. So if I'm doing germline BRCA testing, I'm actually looking for a BRCA mutation which is leading to what cancers it will cause, breast, ovary, or whatever we are looking for. So the reason for doing a germline testing is different. You're looking for the mutation which is heritable and what disease causalities it can cause. Now, the other major mutations important for us is somatic mutations. And somatic mutations, we mean we are looking at the tumor, but we are not looking at normal tumor cells, non-tumor cells. So basically, we are going to study only the tumor sample, and the mutations we find in this, these are the somatic mutations. Now, how do I know whether this mutation is somatic or germline? Now, if I find a mutation in the tumor, it could be somatic, it could be germline. So that's why when you want to clearly say this is somatic alone, you have to also sequence normal cells. And when you sequence normal cells and you don't find it there and you find it in the tumor, you say it is a somatic mutation. Now, why do we do somatic mutation? We are using that for interpretation of the variants which focus on the impact on clinical care. So the reason to do it is, can we do something about it for the care of the patient? And that's why the whole emphasis has to be very clear. So first message, never mix germline and somatic. When you say, I did a testing, please emphasize what testing you did. So tumor testing we do, those are all tumor somatic testings is what we are looking for. But when we say germline testing, we are only looking at the hereditary genes. So very, very important to understand this. Okay, so when we test, what are the abnormalities we're looking for? We can put our genomic abnormalities into three categories. These are three big buckets. You talk about mutations, you talk of copy number variations, and you talk of fusions. These are the major three categories, and everything whatever you find in a test, you can actually put it up into this, or this. If you talk of mutations, there can be multiple type of mutations. The commonest for us could be when we talk about a missense mutation, or a substitution mutation, or an insertion deletion, or what we call commonly indels, insertion deletion mutations. Now, suppose in a colon you saw a KRAS mutation. Now this is a mutation. This is an abnormality you're seeing, a BRAF mutation. And these are the commonest things you're looking for. What are other variations? Copy number variations. When you say a copy number variation, you mean the gene copy number, it's either high or it's low. It's not exactly what it should be. Now, when you have high gene copy number, it's called amplification, and you could have a focal amplification, or you could have a low-grade broad amplification. Commonest for us, breast cancer. HER2 new amplification. Your copy number is high, and that's what's being expressed as, and which you are testing and finding out as HER2 amplified tumors. You could have deletions, copy number variation, where there's lesser number, and these could be heterozygous deletions, it could be homozygous deletions. Now these deletions, like a RB gene deletion in retinoblastoma, this is a copy number variation where you're having deletions in the gene. And the last abnormality, fusions. Now fusions, BCR-ABL fusion, if you take the classical one where we started the first treatment of targeted therapies in cancers, BCR-ABL fusion in chronic myeloid leukemia. Or if I talk of lung cancer, it may be a ALK fusion, it may be a RET fusion. So these are fusions where there is an interchange in the partner, either in the partner genes or in the part of the segments, or between genes or between different genes. So they could be chromosomal translocations, there could be interstitial deletions, it could be inversions, it could be tandem duplications, but these are the fusions which you're looking for. Now, what we need to understand as clinicians is, how do we test for these abnormalities, and is our test actually covering these abnormalities? And that's where all the difference lies, in why some tests will show some and why some tests will not show. So that's why it's essential to understand what abnormality you're looking for, and then how are you going to choose your best test for it. But eventually, every cancer, when you deal with and you say you did a molecular testing or you look at the molecular pathways, basically they will fall into one of these categories of mutations, copy number variations, or fusions. Okay, the another terminology, very important, is this mutation we found functional or not functional? Now, the word for use, if it's a functional mutation, you're actually talking of driver mutations. They are driving your cancer. The rest of the mutations in the background which you're finding, which may not be driving the cancer, are called passenger mutations. So a driver mutation is a genomic alteration that provides a selective advantage to the cancer cell, and that is giving the advantage for the cancer cell to grow, to survive, to develop more, to propagate. And these driver mutations, they may be sometimes actionable and they may be non-actionable. So that's another very important part. Did we find a driver which is actionable, or did we find a driver which is non-actionable? So if I find a KRAS in lung cancer, a KRAS mutation is a driver mutation. But among the KRAS mutations, the only one which can be actionable is a KRAS G12C. I know that's a driver, and that's the one which has a targeted oral tablet. But the rest of the KRAS mutations are non-actionable driver mutations. So that's why, again, understanding the differences between the KRAS mutations is important. In driver and actionable and non-actionable is important. Passenger mutations, now these are the mutations you find maximum in the report. So when you do a sequencing, you find a lot of mutation information, and most of these are passenger mutations. They do not affect the development, growth, or survival of the cancer cell. So that's something that you can't say, I picked up this mutation and I will treat it and the cancer should respond. And that's where we go wrong many a times when we say, oh, there were a lot of mutations in that report. They could all be passenger mutations. And it's very important that we get a clear picture of what is driver and what is passenger. Okay, so now we know what we're looking for. So what are the ways we are looking for these, and what is the testing? And this is very important to understand, because there are a lot of tests in the market. Everyone has a various kind of platforms, and a lot of information will come out, and that's always a little difficult to interpret in practice. Let's start with a single gene test. Now, single gene test means you know the abnormality, you're looking for it. So if I have a breast cancer where I'm asking for a HER2 by IHC, So I did a HER2 by IHC. I just looked whether the HER2 is amplified or not. This is a single gene test. But single gene test means you know the abnormality, and that's abnormality you're looking for. So that's why it's something you do which is very quick. IHC based testing is very good. Or if you wanted to do a HER2 by FISH, you did a FISH and saw the HER2 is amplified. Again, this is a single gene test. But single gene test always has issues. You're going to take a lot of time doing one test at a time, and as the number of tests are going up, single gene test is many a times a waste of time. It's only in selected situations, especially in breast cancer, where single gene test is very, very important. But in lung cancer, single gene test emphasis is becoming lesser and lesser. So what do? Then we do what is called as multi-gene hotspot panels. Now, multi-gene hotspot panels, as you understand by the word, you're looking at multiple genes, but you have created hotspots. You say, I know these are the mutations which happen, and I just look for these. I don't want to look and interrogate the whole gene to find out the abnormality. So now if I have a lung cancer where I know I'm looking for a EGFR mutation. Now I know the EGFR gene lies there, and I know the abnormalities are between codon 18 to 21. Now how do I look for it? I can send sometimes a PCR test where I will say interrogate the EGFR. So when we write EGFR testing by PCR, what are we doing? We are looking at 18, 19, 20, 21, and we are trying to find out whether the abnormality is there or not. This is a PCR-based hotspot panel. But again, when you're looking at one gene, what happens to ALK? What happens to ROS? We are not happy with that. So what do? We do hotspot testing by using NGS. So we get a limited hotspot gene web. So nowadays, most of the labs which come to us, or most of the reports which you will read, which say that we looked at 12 genes in lung cancer. What are they doing? They are doing an NGS. They're doing a limited NGS. They have chosen hotspots, but they are looking at all the common ones in lung cancer. So I send a 12 gene, and that includes EGFR, ALK, ROS, RET, MET, HER2, NTRK, and the other abnormalities which are important. So that becomes a multi-gene hotspot panel. But again, this is much, much better than a single gene test because you're getting all the information in one go. But we need to understand this also is only looking at selected hotspots in the gene. So it will not pick up all the abnormalities. There will be some abnormalities which will be missed out. So how do we go over this? We go over by doing what is called as comprehensive genomic profiling. So when you'd say comprehensive genomic profiling, what it means that we are testing hundreds of genes in that disease-associated genome which have been already known. So this is called next generation sequencing. When we say, I did an NGS test, I did a comprehensive NGS test, then it means I have chosen a test which is doing much more extensive coverage of the gene at a greater depth, and also looking at all the genes which are relevant in practice. Now, when we do a comprehensive gene, suppose I send a foundation one, FMI testing. What is it? It's a comprehensive genomic profiling. It's looking at all the 500 odd genes which are known to be important for cancer, and that's where we are looking at all of those genes as in depth, as much depth as possible. Now, again, there are different types of comprehensive genomic analysis, and that goes into more depth of what is why some tests pick something and why some tests don't pick up something. But yes, if any of the labs comes to us and says, I'm doing a 100 gene panel, I'm doing a 300 gene panel, I'm doing a 500 gene panel, basically we understand they are doing a comprehensive genomic profiling, and this report will give us this depth of information. Now, we understand we are moving to a level where, the more the information, the more better it is, sometimes we think, and that's why you will hear tests called whole exome sequencing. We know exome is the one which is having the coding information. So what we do, you're taking exomes and you're sequencing the whole exome. So you're getting more information than just a comprehensive genomic profiling. Or you can actually do the whole genome. You don't remove the introns. You do the exomes and the introns, and you're doing the whole genome sequencing. And this is the comprehensive, where you look at all the coding regions of the genome and get the whole information, and that's called the whole genome sequencing. Now, there are issues with whole genomic sequencing. You will get a lot of information, and again the same question comes, but we know in cancer only at present we know only about 500 odd genes have relevance, and we don't know what to do about the other information. So that's always the issue. But if you do more depth, more coverage, more broader coverage, you keep getting more and more information. Now, There's another terminology very important you hear many a times. We did RNA sequencing, and we need to understand all the about tests which we were discussing. Most of the information we are doing DNA sequencing. But we know there are certain abnormalities, especially when we talk about fusions, because these are some things you can miss when we do a genomic DNA-based sequencing. So for fusion genes, it is important to do RNA sequencing. Now, where is this important? The newer modalities, especially the newer tests like NTRK fusions. Now, NTRK fusions can happen in many ways with many partners, and these are tests you will not pick up easily if you're doing a DNA sequencing. It's also important to add RNA sequencing to the DNA sequencing to get the information of fusions. So many tests nowadays would have incorporation depending on what you ask for. They will do DNA sequencing, and for certain fusions, they will do an added RNA sequencing. Now, I think sarcomas is becoming so important even for diagnosis. You have to know what your molecular abnormality is, even for the classification of sarcomas. And some of these you will not pick up by DNA NGS. You may need an RNA NGS also for that. And that's why sarcomas, it's very important to use panels which have broad-based DNA and RNA NGS panels to get all the fusion information. But again, RNA sequencing is not something that can be done very easily because there are issues with it. RNA can be very volatile. It can be very unstable. So doing the test sometimes may not give the right answer easily. So these are the ways we test, and these are the different kinds of tests. So conventional testing, now when I tell conventional testing, we know there are limitations, and that's the reason why the whole cancer care is moving towards next generation sequencing and NGS testing. In conventional testing, we know only a limited number of abnormalities are screened for. We have to know the abnormality, and that is the question we ask. Can we see that? We are going to miss all the other things. And when you do conventional testing one at a time, you exhaust the tissue, and so you may not have tissue to really do testing. Just a quick word about all the conventional tests. When we do IHC, we are looking at protein expression, so we know we are looking for HER2. We are not going to find any other abnormality. If I'm doing fish is very good for picking up your copy number abnormalities and your rearrangements. So if I know the abnormality, then I'm looking for that by fish. So if I know I have an ALK fusion, I can do a fish and pick up the ALK fusion. But we understand fish will not pick up mutations very well. So you don't pick up insertion deletions very well. And when we do hotspot conventional testing, that means we are doing a NGS test, but we are doing limited gene panels, as I mentioned above. A hotspot gene, 12 gene panel, it detects very well all the mutations, but we need to understand sometimes basic NGS testings, especially DNA-based NGS testing, may miss some amount of amplifications and some amount of fusions. So again, one needs to understand what test covers which part very well and which is missed. And then depending on what cancer you're looking for and what abnormality you're looking for, you have to keep thinking, is my test covering this or am I missing out on this? So broadly, always remember, if you see fusions or if you're seeing amplifications, sometimes a hotspot gene testing may miss some of these because they are not looking at, they are very good for mutations, they may not be great for fusions. Now, a test which includes DNA and RNA, that's also covering all the mutations very well, but it's also covering the fusions very well. Now, a lot of DNA testing has moved to the NGS testing uses different platforms, and there is something called as amplicon-based and something called as hybrid capture-based. And the hybrid capture-based is better because it picks up more information, and even it picks up much more on the amplification fusions, which we have missed sometimes by the amplicon-based. So we do the test, but we know there are a lot of challenges in clinical practice. What are the challenges we face? We get a lot of information, and the interpretation of this complex readouts of both somatic and genomic germline events is not very easy. And that's very important as clinicians for us to understand this information which we are giving us, is it relevant to our patient or not? We have to distinguish between the finding you get and whether you say there's a clinical value with it. It is actionable or is it non-actionable? We can't say that we find an abnormality and we treat all these abnormalities saying we'll get an answer. That's not the reality of the situation. As clinicians, there's always a risk of overestimating the potential benefits. So because we have seen a few patients with that abnormality working somewhere, we suddenly think, oh no, all our patients are going to work very well with this abnormality. And that may not be reality. And that's the reason we always say, don't overestimate the benefit of the mutation which you see. Try to understand it in the relevance of the cancer you have. Okay. Also, when you do tests, many of these reports will just give the list of information and list of mutations you got, but it does not prioritize alterations. And some of them don't use a ranking system which should be there to understand which of this is relevant and which is not relevant. You may find a EGFR in that report of a lung cancer, and you may find a P53 in that report, and you may sometimes find a RAS mutation, and you kind of think, what is dominant in this and what is driving the cancer? So this is again a very important part to understand. When you see multiple mutations, multiple abnormalities, what is the driver and what are other potential, maybe non-drivers there, or maybe drivers but not to that level. And this is also something which we learn with time. And very important when we meet with patients with this report, understanding the reality of the report and telling the patient the correct information is very important. One cannot really emphasize too much or too less. This is a balanced discussion, and that's why we say nowadays more and more care of oncology is based on a lot of patient discussion to make them understand what that report and information is coming about. So how do we get across the issues which I told you? How do we say which abnormalities are important and which are not to us? It is very difficult for us as clinicians to do that from a report, and that's why there are guidelines for this. There are guidelines which have come from multiple groups which say when you get a report, it should have some guideline followed while reporting so that we as clinicians understand the report. So when we see NGS reports, this is the AMP ASCO-CAP guidelines, which has a consensus recommendation. Now, what this guideline has done is, whenever you get an NGS report, it will have a tier written to it. And this could be tier 1, 2, 3, and 4. Now, tier 1 are the variants of strong clinical significance, and they have therapeutic, prognostic, and diagnostic implication at the current time. They can be level A or it can be level B. So tier 1 level A means there is an FDA-approved therapy, and it is there in all our professional guidelines. A tier B evidence has a well-powered study with consensus from experts in the field. So if you see a tier 1 abnormality written, yes, this is clearly targetable. We know this has a very strong clinical implication. We should go about treating it and seeing what happens. A tier 2 variant is a variant of potential clinical significance. This can come into level C and level D. A level C has FDA-approved therapies for different tumor types or investigational therapies. And there are multiple small published studies with some consensus, but there are no well-powered studies here. Or it could be a level D where there are preclinical trials or a few case reports without consensus. Now, these are tiers where there is importance, and these are tiers that we do consider into treatment. But these are tiers which you have to make patients understand why you're calling it a tier 2 variant and how are you going to address it and what's the reason for addressing it. Now, tier 3 variants, these are variants of unknown clinical significance. They cannot be targeted at present straightforward. So you cannot say, I saw a tier 3 variant abnormality there and I'm going to treat it and my patient's going to respond. There is no convincing evidence in this cancer that the tier 3 variant is driving the cancer. It is a variant you are seeing, but it is a variant of unknown clinical significance. And one needs to understand and not say that we are not there yet, that we are going to treat these. If one really looks at moving to treating these kind of variants, one needs to have extensive molecular tumor boards where everyone discusses these, including having all the clinicians and the molecular pathologists to understand what that variant is and why we are thinking of addressing it. And tier 4 are the benign or the likely benign variants. Now, these are the AMP ASCO-CAP guidelines, but there are other guidelines, and there's another very nice guide, a very good kind of a guideline for clinicians, and this comes with the SCAT guidelines from Europe. Now, what SCAT means? SCAT means the ESMO scale of clinical actionability of molecular targets. Now, what SCAT guidelines does, it looks at two things. It's looking at the mutation, but it is also putting it in relevance of the clinical utility, and then giving you a SCAT score. And with that SCAT score, you say what is the level of evidence. And even this has SCAT level 1, 2, and it goes into various types. But many reports, if you see now, would have mentioned a tier according to the AMP CAP guidelines, but it also would have mentioned an SCAT guideline score, which kind of tells us how important is this mutation for clinical practice. And there's a whole big publication on the SCAT guidelines, which is very interesting to read if one is interested in trying to understand all these mutations and clinical utility of it. So a very important also a recommendation to understand what an SCAT score comes when it comes into the report. Okay, so now we move to what cancers are we testing for? And most important, and the one which actually brought molecular oncology into really prominence, is lung cancer. Because this is where we really understood how the mutations are driving cancer. But more than that, we understood how to target, because this is where all the targeted therapies came in cancer, and that's how lung cancer became the poster child for NGS testing or genomic testing and using into clinical practice. So let me take this example of lung cancer. In lung cancer, now we know we have about 9 to 10 times of abnormalities which we are looking for. And there's no way we will find these abnormalities if we keep doing a single gene testing. So earlier we used to do basic testing. We used to send EGFR by PCR, ALK by IHC, and ROS by FISH. And that's what used to be our testing, because we knew these were the targetable ones. Now we know we have so many more abnormalities, and even by doing these simple testing, we are missing abnormalities. So let me explain EGFR. Now EGFR, we know we have common mutation, 19 and 21. But we know now insertion 20 is a new abnormality which has a targeted drug which is different. Amivantamab is a drug used for exon 20 insertion. And we don't treat it with the same tablets like gefitinib or osimertinib as 19 and 21 abnormalities. So the question is, if I do a single gene testing, there's also a high chance I will miss this EGFR mutation, the exon 20 insertion. So that's the reason why doing some form of NGS becomes important and not doing single gene testing. Now, apart from EGFR, ALK, ROS, we have MET, we have BRAF, V600E, we have NTRK, we have RET, we have RAS, G12C, we have HER2 mutation in lung. We are now coming to new fusions called NRG fusions, which are becoming important in lung cancer. And of course, sometimes we end up seeing BRCA mutations in lung cancer. But except for the BRCA and PIK3 here, all the others are targetable mutations. And we need all this information at one time. So very important that we do NGS testing in lung cancer now, because we don't have enough tissue to waste on this. We can't do single gene testing. We don't have time. And if you have exhausted tissue, you will not get the information. So that's why we send out an NGS test and look for all these informations. Now also look at these. In the side, you will see the SCAT score. If you see EGFR, it is a score 1A. We know it is absolutely a driver. We have a lot of data, we have approvals, and that's why we are using it. Now, if you look at something like BRCA down, BRCA is score SCAT guideline 3A. What it means? We do not have information of treatment in lung cancer with BRCA, and we should not say BRCA will be a driver and treat it. We should understand there's only evidence in other cancers, and one cannot extrapolate it and say this is clearly going to be a very important driver in lung cancer. So understanding the SCAT guidelines also is very, interpreting the guidelines is also very important here. Okay, so lung cancer was the poster child. We have targeted therapies for all these abnormalities, and we have patients whose survival has improved by doing all these kind of testing and treating it in various ways. What is our lung cancer algorithm nowadays? When we see stage 4 lung cancer, we just differentiate adeno and squamous, and then we send a molecular test. And if a molecular testing abnormality is present, then we treat with targeted therapies, irrespective of the PD-L1. We're not so important PD-L1. We say the molecular test report is very important in lung cancer, and to wait for the report if the patient is asymptomatic. But if they are symptomatic, you can still start some form of chemotherapy. Now, if your molecular test is abnormality and your PD-L1 is high, we give immunotherapy. But if the PD-L1 is low, then we give immunotherapy plus chemotherapy, and this is our approach. But now we are moving to the next level, even in lung cancer. We are identifying more mutations in NGS. There is something called an STK11 and KEAP mutation, which shows that single-agent immunotherapy may not work very well. And these patients in lung cancer may be resistant to single-agent immunotherapy, and one needs to move to double immunotherapy combinations. So again, NGS testing is giving us information of how to use immunotherapy in lung cancer, and these are the ways we are moving forward. Okay, some other cancers where it is very important. Cholangiocarcinomas now have become another very important cancer where you want to do NGS testing, because you're looking for IDH1 mutations, you're looking for FGFR mutations, you're looking for NTRK fusions, BRAF V600E mutations, some HER2 amplifications, and you can have some patients who have a BRCA mutation. So cholangio is the next cancer where we talk. A lot of information is nowadays required, and that's why it's better to send out an NGS, especially in metastatic cholangiocarcinomas. Prostate cancer, again, for prostate, BRCA1 and 2 is BRCA2. These are the dominant mutations which are important, but we know we need all the HRR genes. So when you look for HRR genes, you're looking for ATM, PALB2, you're looking for all the RAD51s, and you're looking for all the other small number of genes. Now, getting this information has become more important, and that's why in prostate cancer also it has gone to level of doing HRR testing. So you do an NGS panel and then you get the HRR testing information. Ovarian cancer is very important, though we earlier used to say let's do BRCA testing, Germline and BRCA Somatic, but we know we have a huge percentage who have HRD mutations. Now, BRCA Germline is about you pick somewhere about 12 to 15%, around another 5-6% you pick BRCA somatic mutations. So 20% would be BRCA mutations. But we know another 30% will have HRD mutations, which can be coming out from all the other genes which we see here. And these 50% patients, these are the ones who will respond very well to PARP inhibitors in treatment. So doing ovarian cancer HRD testing has become very important, and that's the reason why if you have to do HRD testing, you actually have to do an NGS testing. So you send out, it's just the labeling is different. When you send out, you are asking for, please do HRD score and HRD testing and give me, and they are looking at all this, and then they are preparing a HRD score and then giving you the report. But eventually the testing is looking at NGS testing in ovarian cancer. Colon cancer, for a lot of times, we were only sending out single genes. We used to do KRAS, NRAS, BRAF. And then after the coming of MMR, it became very important. KRAS, NRAS, BRAF, MMR is what we used to say. But slowly we have increased the genes. Now HER2 has become very important. So in colon cancer, in many situations, we still use single gene testings many a times. It's not wrong to do that, but getting more and more information is becoming important. So many a times now, many people would just send out a colon cancer NGS panel to get all the information in one go. Breast cancer is one cancer where we still rely on basic testing. Breast cancer is a place where we don't do NGS testings upfront, because our importance of treatment has always been on ER, PR, HER2 and by IHC, or HER2 by FISH, depending on what abnormality we're looking for. But where do we do NGS in breast cancer? Now we do more and more NGSs in progressive diseases, patients who have advanced disease who are progressing, because you are looking for some drivers which you can target. And one of the most important coming out is HER2 new mutations. So we know HER2 amplification is right there in that percentage, but now we know HER2 mutation could be a resistant mechanism, and that can be targeted. We are looking for somatic BRCA1 and 2 mutations, and we know these can be targeted by PARP inhibitors. And also AKT, the PIK3 AKT pathway has become very important to understand, especially with new drugs being approved. We've seen recently capivasertib, the AKT inhibitor, is approved for patients who have a PIK3 pathway abnormality. And if I mean a PIK3 pathway abnormality, I'm saying the abnormality could be it could be a PIK3 mutation, it could be AKT mutation, or it could be a PTEN loss. So one of these mutations, this is where capivasertib has approved in hormone-positive patients as they progress into the second-line therapy in the metastatic setting. So if we need to get all this information, then doing an NGS is becoming important. So that's the reason why in progressive disease in breast cancer also, we do NGS testing to find out all these abnormalities. Now, another very important agnostic approval is MMR and MSI. Now, I want to be very clear on this when we use terminologies. We mix these up sometimes, and I always say, if you're doing an IHC-based test and you are looking at deficiency in one of the 4 MMR proteins, MLH1, MSH2, MSH6P, MS2, please report this as deficient MMR. So when we hear deficient MMR, we know the IHC, it has an IHC-based test and it is reporting the protein loss. Now, if I say MSI high, I automatically mean it's either a PCR-based test or an NGS-based test. It's not a IHC-based test. So that's why when you use the terminology correctly, the person who sees the report can understand it very easily. The problem, we know they are interpreting the same information. If you say deficient MMR or a MSI high, you're giving the same information. But I always believe it's important because terminologies can help us tell what the abnormality is. So if you did IHC-based test, deficient MMR is the reporting you should say, or proficient MMR is the reporting you say. Now, this is really very important. MMR testing is kind of very tumor agnostic. We know how it has changed cancer care. It's the way we used to talk of deficient MMRs in colon cancer, in stomach cancer, and now we have moved to so many cancers. We know patients are doing so very well. In endometrial cancer, deficient MMR has become a dominant treatment modality for our patients in the metastatic setting. Cholangiocarcinomas, gallbladder cancers, all of these cancers can have deficient MMR. So testing for deficient MMR is very important because they respond extremely well to immunotherapy. We ourselves have patients who progressed on multiple lines of therapy and tested and found to have deficient MMR, went into CR, complete remission after immunotherapy, and now treatment stopped, are doing so well for many, many years. So that's the reason why deficient MMR is an abnormality which we need to find by doing testing, and to treat with immunotherapy becomes important. Now, the testing abnormalities could also, so if you say MSI high, you could have done it by PCR, and when you see 2 or more microsatellites, you say this is MSI high, or you can do it by an NGS panel, which can also identify MSI high status. So this is tumor agnostic. We know immunotherapy works very well for MSI high tumors or deficient MMR tumors. I always am a very big proponent of MMR testing by IHC. The reason is it's in-house. You get the answer in 48 hours. You really don't need to do the whole PCR test or a NGS test. Of course, the NGS, when you send out, it will give you the information also. But MMR testing is in-house. So all colon cancers, all endometrial cancers, irrespective of stage, please make it a habit of asking for MMR test. Don't really wait for a reason to test later. Any colon cancer you see, do an MMR test. Any stage, and any endometrial cancer you see, any stage, please do an MMR testing. It has implications even for Lynch syndrome, because once it becomes deficient MMR, then depending on the abnormality. So if you see a colon cancer which has a deficient MMR, then you can do a BRAF testing, and if the BRAF is mutated, you know this is somatic, and if the BRAF is non-mutated, it is pointing to germline testing, and then you need to do a germline test and prove that you're dealing with Lynch. So just that one simple test can guide you in many directions, and it is standard of care to do these even in early stage in colon cancers and endometrial cancers. Another abnormality, very rare, NTRK fusions. Now, NTRK fusions, it has an agnostic approval because there are drugs which work very well, but they are so rare to find. On the whole, if you put all solid tumors together, they are present in less than 0.3%. But there are certain cancers where they are present in very high frequency. So if you see a mammary analog secretory carcinoma of the parotid, or if you see a secretory breast carcinoma, if you see an infantile fibrosarcoma, these are tumors where NTRK fusions may be present in more than 90% of patients. So these tumors surely needs to be tested for NTRK fusions. Now, if you see certain tumors like thyroid cancer which has progressed, or if you see a GIST which does not have any of the mutations, we used to call them the non-driver GIST, where you did not find the KIT, you did not find the PDGFR, you looked for it. These are the ones who may actually have an NTRK fusion. So these are also ones you check for NTRK fusion. And there are common cancers where it is very rare. So if I do lung cancer, the NTRK fusions is 1%, less than 1%. But we do it. In colon cancer, it is less than 1%. But these are places where, again, you may find an NTRK fusion. And the reason you do it is because you have these drugs. You have the first generation drugs, larotrectinib and entrectinib, and now you have also the second generation drugs, the selitrectinib and the repotrectinib, and they have shown amazing responses in patients with advanced malignancies, even progressive disease, who carry the NTRK fusion. So NTRK fusion is again a pan-agnostic approval. You need to test your tumors, and the only way you can test and find NTRK fusions is if you're doing a comprehensive next-gen sequencing, which is involving and looking at all the NTRKs. Now, This is one place where RNA fusions are also very important, because by doing RNA testing, you can pick up much more enteric fusions than doing only DNA-based testing. TMB testing, this is tumor mutational burden. This is also has a tumor agnostic approval for patients who have progressed on multiple lines of treatment. Now, TMB has technical issues. You cannot get a correct total mutational burden score information if you do a limited gene panel. So someone says, I did a 50 gene panel or a 100 gene panel and give you a TMB score, it may not be relevant. Ideally, TMB should be done by either whole exome sequencing, whole genomic sequencing, where you looked at a large number of genes and then calculated the mutational burden. But we know comprehensive genomics testings like Foundation 1, MSK Impact, all of them, they actually looked at these 350 to 550 genes, and they correlated with the whole exome sequencing and said that that score which they got from that genes is similar to what you would get from a whole exome sequence. And that's the reason why a comprehensive test which includes about 300 to 500 genes giving us a TMB score is reliable. Now, where is it especially important? In patients who have multiple progressive cancers in the metastatic setting of cervical cancer, salivary gland cancer, thyroid cancer, NETs, vulvar cancer, this is where TMB becomes a very targetable, and pembrolizumab has approval as a single agent in late line settings. Now, one more word is, don't go on TMB scores on liquid biopsies. They are very tricky. They overestimate the TMB. So solid tumor TMB is always a gold standard. Okay, so we also now are moving to an era where, we talk so much about liquid biopsy, and we hear this term so commonly. I sent a liquid biopsy test, but what are you testing for becomes very important, and understanding that becomes very important. There can be various liquid biopsies. You talk about ctDNA, that's the cell-free tumor DNA. You talk of CTCs, circulating tumor cells. Nowadays they're talking of TEPs, tumor-educated platelets, and these are different forms of liquid biopsies. But the one which is most relevant to us is ctDNA, the cell-free tumor DNA, and this has become a way by which we overcome some of the shortcomings of tumor testing. So what is liquid biopsy? You take the blood, and there you are doing a cell-free tumor DNA. But mark you, a liquid biopsy is not same as if I'm saying I'm doing a germline testing in blood. A germline testing in blood means what? You are sending a blood sample where they are going to look at the abnormality, like a BRCA mutation, or if I did a hereditary NGS panel on blood, I am looking at all these abnormalities in the normal cells. So what I'm doing, I'm seeing a germline abnormality. When I'm sending a liquid biopsy here for advanced cancers, I am looking at these abnormalities on a cancer cell. So you're first isolating the cancer cell, and then you are looking for these abnormalities. So these are somatic abnormalities, what you're looking for. Now we know when we don't have tissue, cancers progress, we can't biopsy, we do liquid biopsies. We send it cell-free tumor DNA on the blood, and these are very reliable. Now earlier we used to say do it when tissue is not available, but now we understand they complement. And even if tissue is negative, you can get more information from a liquid biopsy. Heterogeneity is an issue in tumors, and liquid biopsy overcomes this issue of heterogeneity. And we are seeing liquid biopsy reports come much faster, and you don't need tissue, you don't need waiting time, and that's why you actually can get reports of liquid biopsy much, much faster. But again, whenever you're doing a lot of liquid biopsy testing, understand there are a lot of pitfalls of liquid biopsy. Don't say all my liquid biopsies are excellent reports. There is reports where you would do it and you would see it is negative. And this is because one needs to understand there is variability in ctDNA shedding. Not all tumors shed well. A prostate, a pancreas doesn't shed so well. A lung sheds really well. A GBM cannot shed sometimes into the blood because of the blood-brain barrier. Tissue of origin matters. And then as age happens, there is something called as CHIP, or clonal hematopoiesis of indeterminate potential. That means there are some mutations with older age which happen, which will be picked up in a liquid biopsy. They are not cancerous mutations. So one needs to distinguish this when we see a report. So when should genomic testing done? We should do genomic biomarker testing. When we are talking of somatic testing, you always do it when you're looking for some therapies. And if there's an approved therapy for this, or there's a clinical trial of some drug, this is why we do genomic testing. Another thing is important is one should understand and do it in a very balanced way. We should see patients' performance status, comorbidity, cancer stage. Though more and more genomic testing is being done, but one needs to be really balanced about which patients to choose and do it for. It should not be blindly for everyone. But yes, the utility is going up more and more. applications of liquid biopsy has moved, and this is how the science is changing. We always talked about, we do these liquid biopsies because we want to find the genomic abnormality which we can target. It's all about precision medicine. But now we are moving the science forward. Now in a lung cancer, we are doing tissue and liquid together in many of our situations because we know we will pick up more mutations. But sometimes you are also looking for concurrent mutations which may cause resistance. Now, if I have an EGFR and I have a P53, I know these patients may not respond so well to the EGFR drug, though normally EGFR responds. And that's why getting a concomitant resistant mutation is very important. We have moved liquid biopsy into monitoring minimal residual disease and taking decisions on this. So the classical example, colon cancer dynamic study. Last year we saw it in ASCO, and after that it's been such a talked about study. In colon cancer stage 2, we used to treat patients only on the clinical decision. We used to say, our stage 2s are high risk or low risk on our clinical decision. So if I have a T4, I have a lymphovascular invasion. These are, if I have an obstruction, I didn't see enough nodes, I would take a decision and say, give them chemo. Otherwise they are low risk, don't give them chemo. But we saw the dynamic study last year. We looked at testing, and they sent the blood for minimal residual disease by doing NGS testing, and they looked at the NGS and said, those patients who were self-treatment DNA had MRD positive, only they were given chemo. And those patients who had negative MRD in stage 2 colon cancer were not given chemo. And they saw there is really no difference. It was a non-inferiority study, and there was really no difference. So in stage 2 colon, now it is becoming standard. Slowly everyone's adapting into this, or doing a proper MRD testing to understand whether is chemo required or not. And everyone hopes that now stage 3 trials are ongoing. So in colon cancer, we may have a MRD test to decide who requires adjuvant chemo and who does not require adjuvant chemo. But mark you, these are not the common tests which you talk about, NGS in the blood. These are a different level of testing of MRD. The NGS sequences and platforms use either genomic information or epigenomic information together, and then they give a MRD detected limit or not. So this is not the common NGS which we use in our clinical practice. Another important important use of liquid is monitoring treatment response. You started treatment and the variant EGFR level comes down in lung cancer as soon as you started osimertinib, and this is telling you response. So these are ways by which people are looking at different responses. The understanding clonal dynamics, understanding subclones. Breast cancer, when you start treatment with, in metastatic setting, in ER positive setting, you started AIs with letrozole. Suppose you did letrozole and palbociclib, and as you went to treatment, when they progress, you decide to do an NGS. You see there is a ESR1 mutation. Now understand, ESR1 is a subclonal mutation. It has happened on treatment on the ER pathway, which has been blocked for time. And this subclonal mutation proves you are resistant to the AIs, and you need to move to a fulvestrant-like drug. So this is understanding the tumor dynamics and understanding how the subclones develop so that we can target them better. And the most very intriguing aspect of now liquid biopsies is early detection of cancer, which is really being looked at in a big way. I'm sure in a few years we'll have tests which have proven in clinical trials that they help in early detection of cancer. But we are not there yet for using liquid biopsies in that situation. I would like to kind of finish off saying that there are other important considerations in when you order a test, when you interpret a test. You should understand how the lab is, because there will be multiple labs who come to it. Are they certified labs? Have they done some concordance and some studies? What are their limitations? Or what every clinician should understand the test they order for. They should understand the lab interpretation. And that's the reason in India sometimes things become difficult, because there are so many reports which come out. So for clinicians, sometimes a report will be positive from one lab, negative from another lab. You need to really interpret and understand by asking the right questions. So understanding and interpreting the report is very important. So this is my last slide. Comprehensive genomic profiling is changing cancer care, and every patient's pathway is changed now. We have moved to that level where we cannot do without these kind of tests. So some of us are slow adapters, some are early adapters, but we need to understand the science behind it, and we need to understand why it is changing everything. So it is you are giving not only the right treatment for the right patient as precision oncology, but you are going deeper and deeper. You're going broader, and you're changing the healthcare systems, you're changing dynamics, you're changing a lot of healthcare-based decisions for the government also. And slowly, more and more agencies are understanding why NGS is important, and they are giving acceptance to that for using in clinical impact. So I think CGP is here to stay. So all of us need to understand all the nuances of CGP and use it wisely in our clinical practice. Thank you very much.
Thank you, Dr. Amit. You may stop sharing the screen, and Lithuanians, if you have any questions, you may type in the chat box.
So there's one question: what is depth like 20x, 2000x? Yeah. When you sequence in NGS testing, what you're doing is you are running the test multiple times when you're doing a PCR. So you have the steps in NGS testing. You are first extracting the DNA, then you are you're creating a library, then you are doing a repeated PCR testing, and then you go down to different levels of testing, and that's why they say this is into this much X. Now, it is not that for a tissue NGS, for a tissue testing, it's not that more the X, the better it is. It is not like that. There is a certain amount which is important, and that is the relevant amount. But more than that may not be too relevant. But when you're doing a liquid biopsy, there it becomes very important because you have very few cells in the blood, and that's why you need to really pick out those cells and then sequence it. So that's why when you do liquid NGSs, your depth of you'll see the X is much more there. But these are basic informations which come out in the report that we did a test with this much X to get this information. Okay, so are there any short-term programs where you can learn more genomics for a surgical oncoresident? Okay, so I think there are small programs. There are also some online programs which do teach about genomics. But yes, I just covered the very, very basics because we see these reports in front of us. So all of us should at least know the basic terminologies and understand it in a very basic way. Are all germline testing is done by liquid biopsy blood? Yes. So germline testing is always blood-based testing. What we used to do earlier, it's you just say blood testing for germline. So what you mean basically, you are going to test by doing on the normal cell. So earlier it used to be Sanger sequencing. So when you did BRCA1 mutation, you want to find out, you used to do a Sanger sequencing in the blood on the normal cell. Nowadays, more and more platforms, they don't do Sanger sequencing because it's going to take a lot of time and effort to find out a single gene abnormality. So what they do an NGS on the blood. Now NGS, when you do it on a normal cell on the blood, you're looking for a hereditary mutation. Now when you're doing NGS on the blood on the cancer cell, it is the NGS which you're saying is a somatic NGS. So that's why just if you see blood NGS shows a BRCA mutation, the first thing you need to do is look at that report on top and read what was it done on. So it was done on a normal blood cell. Then this is a germline report. But if you see this BRCA mutation, NGS was done on a tumor cell on the blood. This is somatic NGS. And yes, we see this in some labs. Don't even mention this. You have to get back to them and ask them where was this done on, and please emphasize, because hereditary information is very, very important, and hereditary information and talking to families becomes very different. You overestimate TMB? Yes, absolutely. Don't rely on TMBs from liquid biopsies. So don't say, I saw liquid biopsy, high TMB, maybe 20, and I want to give immunotherapy to my patients. You will most probably go wrong. Look at broad tissue biopsy platforms. So most liquid biopsy platforms just look at limited genes. Some of them look at 50 genes, 75 genes, though there is Foundation 1 liquid which is looking at 350 genes or more. But liquid NGS is overestimating TMB, so be careful about it. How come they overestimate? That's the way the platform is designed for them, and most of them, because they do a little low number gene testing, that's the way it is coming out. So use tissue when you're thinking of treating on TMB especially. At present, when we give chemo in stage 2 cancer, so we have actually we still for most patients do clinical testing, but we have used already the new platform of testing. It's a different kind of a platform where there are a couple of platforms in the world. There's one called Signatera where they do tumor-informed liquid NGS, where you first see the tumor, make a type of NGS panel, and then look for it in the blood for MRD. Or there's a tumor uninformed panel called the Guardant Reveal in the US. So Guardant Reveal is like something you're looking at both genomic and an epigenetic information to know whether MRD is positive or negative. So we have done this in our patients. We have looked at Guardant Reveal whether they are positive or negative. If they are two tests negative, we say no adjuvant chemo. If any one test positive, we say adjuvant chemo. But it is changing the field slowly. In stage 2, the dynamic study has really changed our perspective about it. I'm very interested in those. There's a Galaxy Circulate studies which are going on in Japan, and there are multiple other studies going on in the US and Europe which are looking at stage 3 patients. And if that becomes practice changing when it comes into clinical practice with good clinical trials, because we tend to think with stage 3 we overtreat many patients, so it would be very nice to know which patient to treat or not. But as of now, we are not there in stage 3 yet. We cannot take a liquid biopsy MRD testing for clinical use in stage 3 colon at present. Solid organs also mutations are actionable or not, and all the mutations I have mentioned as well. So that's the problem, in testing you will get a lot of reports saying a lot of mutations. Some will be actionable, some will be non-actionable, some will not even be drivers, they'll just be passenger mutations. So very important that our lab which does the test actually curates the report better, and that's the reason why we are saying a good standard lab should mention the CAP guideline tier variant, which is it. Also, you're seeing now many labs are also mentioning the SCAT guidelines. That means they have looked at it to that level, they have curated it, and they have found out what is relevant and what is not relevant. So for us as clinicians, first information is going to be from the report, but then all of us need to sit back and look at our clinical information and take a call. And that's why the experience of using more and more NGS will come into practice, whether is this report really relevant or is this report not relevant. Is MSI testing needed in all stages of colon cancer? Absolutely. I think this is something we have propagated for many years. Don't wait in colon cancer for stage 4 patients and then say I want to do an MSI test or an MMR test, because there you are using for a therapeutic implication. But in all stages it is very important, because there is a potential there could be lynch, and we know we won't pick them up if we don't do the test. So in our hospital for many years now, in the lab there is a standing instruction. If you see a colon cancer which gets operated in early stage, they give the report of adenocarcinoma with the stage. The MMR report is there with that. We always say it should be there in the universal guidelines, MMR testing for every colon cancer. So we used to say stage 4 important because of immunotherapy. We used to say stage 2 important for clinical decision of whether to give chemo or not. We know in stage 2 MSI high patients, you don't require adjuvant chemotherapy. You can avoid chemo in those patients. Also, we used to say sometimes in stage 2, if you require chemo, don't give single agent 5FU, because single agent 5FU doesn't work very well for MSI high patient. But implications of colon cancer have very widespread. I would say every colon cancer you say, please ask for MMR IHC. You don't need to ask for MSI by PCR, because then it has to go to an outside lab. It may take more time. Just get the MMR IHC done and get the report in 48 hours. Get that information. And if it is MMR deficient, then depending on your stage, you decide whether you want to look for lynch or not. You should look for lynch if you have a MLH1 mutation, MLH1 deficiency. This is MLH1 MMR deficient tumors. These can be lynch or this can be somatic. So do a BRAF testing. Now, if the BRAF is mutated, then this is somatic. This is not lynch. But if your BRAF is negative, then there's a high possibility of this being lynch. But this is especially only if you have an MLH deficiency. MSH2, MSH6 usually are lynch. Again, you do a blood germline testing and prove that they are lynch. Do we have whole genomic NGS platforms in India? Do we need to send FMI? No, it's not like that. There are a lot of platforms now in India who are doing whole genome sequencing, whole exome sequencing. There's a lot of labs which are doing this information. But to interpret these reports, you really need to talk to the labs to understand how are they what is their bioinformatics platform, how are they reporting this, because some of these informations which they get may be relevant, may not be relevant, and the bioinformatics platform is very, very important to give that information. So that's why I would say you don't need to do foundation one always, but foundation one is more, it is FDA approved, so that's why you can rely on those reports. The way testing they have done for years, the way the interpretation has been, it's very, very reliable. So that's why sometimes when cost is not an issue and we want great information, we say, okay, send out one of those comprehensive platforms which are present, like Foundation, Caris, Guardant, one of those which has been time tested and proven. But now there are many Indian labs doing tissue NGS, and tissue NGS is really good in our Indian labs. Information of bioinformatics and interpreting the reports is also very important. A question of hybrid capture versus amplicon capture NGS. Yes, so this is important because